To improve our simulation education, we've put together a program where we're going to do two things. Number one, we're going to help you to be better clinically for the real bad emergencies that come up. And number two, we're going to do some initial preparation for the OSCE part of the boards. So, simulation should help you clinically and should help you pass your boards, and that's what we're going to do here. What we've done to improve you clinically is we've come up with 5 extremely dangerous emergencies that you're going to face. Rather than create a kind of a gotcha environment where you come down here, we put you through an emergency, we say, aha, you forgot this or you forgot that. What we've done instead is we're going to give you both a written list of things to do, and we're going to give you this, which is what amounts to a video answer key. So you'll be able to read about what you're supposed to do, and you'll be able to see in action someone doing it correctly. The idea is then you will come to the Sim Center and demonstrate that you've learned these things. If you miss something, we'll go over it again. The idea is to go over these emergencies again and again and again through the years of your residency, so that when the real emergency happens in real life, you'll know what to do. What do I mean for an example? Well, we're going to do a stat C-section, and I'm going to go through the major things you need to do in a stat C-section. We're going to do a full arrest that comes flying into the OR. We're going to do a cerebral herniation that's just about to happen right in front of your eyes. And we're going to do coming off bypass. And we're going to do the thing that especially anesthesiologists worry about, which is can't intubate, can't ventilate. And again, we're going to write out what you're supposed to do. We're going to demonstrate what you're supposed to do, so that way you can see and practice and read about it ahead of time. Then you'll come to the Sim Center, and several times, rather than a scattershot, simulate this or simulate that, we're going to have you go over and over again those big bad emergencies so you're ready for them when the time comes. The second thing we're going to do is the ABA has just created this brand new OSCE idea, so there's going to be an OSCE part of your oral board exam. They've sent out the kind of things they're going to ask you, and what we're going to do is, same for the clinical emergencies, we're going to demonstrate how you might answer these. So the idea is, rather than drift into the OSCE exam and part of the board is, oh, what's going to happen? It's like, oh, we've already practiced what could happen. So, in summary, we're going to help you out clinically, we're going to help you with the boards. First thing we're going to start with is a stat C-section. First, I'm going to do it in kind of slow motion, and then so you can really process what each of the steps are. And then I'm going to do it in a little faster motion. This isn't absolutely everything in the world, but these are the main things, so that when a stat C-section comes down, you know what to do. So, first thing, stat C-section. Quick airway assessment. I don't care how emergent it is, you can at least get a quick look at the airway. Anything looks at all doubtful, get a glide scope. Because if it's a stat C-section, that's probably involved a general anesthetic. So, quick airway assessment. Ideally, you've actually assessed everyone who's out there on the floor, so you know if anyone with a difficult airway is coming. So, quick airway assessment, preparation for in case it's a difficult airway. Second thing, quick left uterine displacement. Easy thing to forget in the panic as you're rushing into the room and stuff. But remember, let's maybe get the baby into left uterine displacement. Hey, maybe all of a sudden the fetal heart rate will get better and we won't have to do a stat section. So, left uterine displacement. Pre-oxygenate. I want it because it looks like you're going to be doing a general anesthetic. If this is a stat C-section, you're going to be doing a general anesthetic pretty quick. So by all means, start pre-oxygenating. You're going to be doing a general anesthetic. Make sure the IV's working. IV could have infiltrated. In the rush over here, could have gotten knocked out. Make sure you got to have an IV to do a rapid sequence induction. So make sure the IV's working. Now, if there's any chance at all that you can do a regional, this is the time to ask the obstetrician, hey, is this so bad that, can we maybe put her on her side and do a spinal? So you can always ask, maybe we don't have to do a general. If she's got an epidural, maybe we can dose it up fast. So do explore the option of a regional on the off chance there is time. Again, if it's a true stat C-section, there won't be time. Now you do a rapid sequence induction, being aware of the aspiration risk. Secure the airway. off they go. And once you've done that, if it's a stat, they might be bleeding a lot. At that point, airway secured. Now get additional access. Maybe get an art line if you need it. So that's how you go through a stat C-section. Now, I went through it deliberately. Now I'm going to go through it just a little bit faster. And again, what's the idea here? You're going to read about this, you're going to see how I did it, and then you're going to come to the Sim Center and you're going to demonstrate that you know all the steps. So this time it's going to be a little bit faster motion. Stat C-sections, rolling in. Quick airway assessment, might be difficult. Got the glide ready, okay. Let's get some left uterine displacement, okay. I'm going to give her some oxygen. Any chance we have time for a regional? Maybe do a quick, okay, can't do it, all right. Make sure this IV is working. All right, we're all set to go. Rapid sequence induction, airway secured. All right, they're proceeding with dissection. Now, additional access and art line. So, those are the major steps when you do a stat C-section. Again, as in the stat C-section, I'll go through it sort of slowly and deliberately, focusing on each step, and then I'll go back and do it a second time in sort of more real-time motion. So, we have impending cerebral herniation. Blood pressure is sky high, heart rate's low. Classic Cushing's triad. Take a look, maybe you see a pupil's blown, and it's evident that the came from CT scanner, looks like he's going to herniate. So, what do? Well, you want to get their head up. Boy, you want to get that intracranial pressure down. As with everything, you want to do the world's quickest airway assessment. You are going to have to secure the airway. So quick, take a look, grab glide scopes or help, anything you need, because you are going to be having to secure the airway pretty quick here. So quick airway assessment, the head's up, and now you're going to be pre-oxygenating. You're letting neurosurgery know that, you know, they better get in here fast. You know, this is not a routine case. They're going to have to open up this head quick and get the blood out or something along those lines. We now do a rapid sequence induction. Keep in mind, full head, full stomach, so anyone who's in this set of circumstances, you have to consider them aspiration risk. So we do a rapid sequence induction, we secure the airway. Once the airway is secured, we're making sure we're running in something like mannitol or 3% saline to try to decrease the swelling. And another key thing is we're going to be maintaining cerebral perfusion pressure. So as you do your induction, you don't want to drop the blood pressure to, quote, normal, 120/80 say, because this person actually needs the high pressure to get the cerebral perfusion pressure up. So those are the sort of a slow, deliberate way of looking at managing impending cerebral herniation. Now we're going to go through it more like how you might go through it in the real world. Boom, through the door he comes. Hey, this guy might be herniated. He's blown a pupil. Oh, okay. All right, let's check out that airway. Okay, get me a glide in case I need it. Let's neurosurgery know we're going to need to open up right away here. All right, okay. I'm going to do a rapid sequence induction. Secure that airway. Okay, once the airway is secured, I'm going to be running in mannitol 3% saline, try to decrease the perfusion. Okay, then I quick take a look, being careful to keep the blood pressure elevated, not too high, but not too low, maintaining cerebral perfusion pressure. Let's go through it again one more time just to make sure you got it. Might be herniating. Oh, heads up, manage that airway, reoxygenate, get neurosurgery, we're going to need their help. All right, rapid sequence induction, secure, mannitol, let's get that swelling down, quick, maintain the cerebral perfusion pressure. So those are the main steps in managing impending herniation. The next emergency we're going to go through is the full arrest that comes flying into the operating room. As before, I'll do this slowly, step by step, and then I'll do it more the way it would go in real life. This is the kind of thing you might either have fly into your room, or you might hear in another room, any anesthesiologist's room, 5 stat, and you come in and there's an arrest in progress. So this is how it usually goes. They come flying in the room. It's a big tangle. Stuff is wrapped around. People are yelling and screaming and stuff. So take a breath, and first thing you do is quick airway assessment. Just like always, is the tube in. So they might have an endotracheal tube in, you want to make sure that it's actually in the right place. It could have just been jostled out in the panic and in the rush and stuff. So make sure the airway's actually in. CPR will be in progress. Make sure good CPR is going on. Anybody can be doing CPR, but maybe it's a student with little experience, so assure that good CPR is going on. Someone in the crowd must have some idea of why this happened. Your money, your two money bets are, it's a volume thing, they've lost a ton of volume, trauma case, something like that. And the second thing is some kind of cardiac event. So someone had an MI in the cath lab, someone had an MI in the field, or something like that. So volume and a cardiac event are your money event. But try to find out from somebody, why did this happen? We're low on blood, the crit's 5. Okay, good, at least things are bad, but at least you know why. So determine what is the main thing. Now, the problem you're going to have is there is going to be a tangle of lines. There's going to be lines everywhere. There's going to be pumps, there's going to be drain. It's a nightmare when they roll in. There's lines everywhere. What you need to do is trace down and find one line and one place where you can inject. That's what in all this mess, just find one IV that is yours and yours alone. In that, you can give your medications because it's going to be too hard to just straighten everything out. Once you have that one IV that is yours and yours alone, you can then proceed to, if the airway's not yet secured, give medications to secure the airway. Keep in mind, if they're in full arrest, you don't need to give any medications, you just intubate. But that's the main thing. In this rat's nest, find one thing that is yours, okay? Now, once you have secured the airway and are assuring CPR is being done appropriately, then you try to fix the problem that they've identified. So if it's volume, you pour in the volume. Make sure the CPR is still going on. And then once that is in progress, by this time usually the surgeons will be opening to try to stop the bleeding or something. At that point, make a point of straightening everything out. Get the IVs in the appropriate place and slowly and deliberately untangle the rat's nest so that you can know where you're infusing medications, where you're giving volume. It takes a lot of time to undo it, but that's what you want to do. So that's how you manage the person who is in full arrest. Now, we're going to go back. We're going to do it a little more like you might do it in real time. So they come flying in the room from wherever it is. Things, okay, first thing, all right, make sure the CPR is going well. Is the tube in the right place? Assure that it is. Okay, who's got an idea of why this guy arrested? Okay, it's a cardiac event. Okay, maybe we need some epi. Okay, so at least we have an idea. All right, now in all this tangle, I found one place, one IV that's mine and mine alone, and through this I can give my medications. Now the airway's secured, CPR's in progress, surgeons are moving to address the problem. Now I'm going to slowly straighten all the lines out. And that is how you handle someone who comes flying in the room or when you have to run into a room and they are in full arrest. The next thing is coming off bypass. One of the problems that often happens is you're doing hearts and at first you're kind of just keeping the record and you don't actually make the decisions. So one thing we want to make sure is that you're confident in actually bringing someone off bypass. Ultimately, when you graduate, you may go out to a job where you do hearts. It's worth noting that you may sign up for a job where you don't do hearts and then the hospital changes management and all of a sudden you do have to do hearts and you go, ah. So we want to make sure by the time you graduate here that without doing a cardiac fellowship, you can bring someone off bypass. So let's go over bringing someone off bypass. As with the earlier examples, I'll do it slowly and deliberately, step by step, and then I'll go back and do it a little quicker. So we're about to come off bypass. You just think of the ABCs. So A, airway, turn the ventilator back on. Take a look in the field, make sure both lungs go up and both lungs go down. This is the time I've picked up right main stems. You just see the right lung going up. So you turn the ventilator on, make sure the lungs go up and the lungs go down. They have to go down because if they go up and they stay up, called kissing lungs, it's going to be in the surgeon's way. You have to suction or give bronchodilate or something. So we took care of A. What's B? Well, B is bureaucracy, and that's when you check with perfusion to make sure that from a metabolic standpoint, everything is taken care of. You want the best possible metabolic milieu, if you want to put it that way, to come off bypass. That's your best bet. So you check with perfusion after the A. Okay, are we warm? Is the potassium okay? Is the pH okay? Is the hematocrit okay? If someone has a really low hematocrit, you might need to transfuse them, particularly if they have multi-system disease. And has the clamp been off, if you're doing a on-pump case? Has the clamp, well obviously you have, been off for 20 minutes? You need 20 minutes to wash away the evil humors from the heart. So we did the A, made sure the airway's working. B, checking with perfusion. Again, let's go over it. pH is okay, temperature's okay, K's all right, hematocrit's okay. Heart's had 20 minutes to rest. Okay, so now I've taken care of B, the bureaucracy. Now C, circulation. Remember, for circulation, there's three things in circulation: rate, rhythm, and contractility. So first, take a look at the heart rate. Make sure the heart rate's okay. Maybe they have to put in a pacing wires if there's not an adequate rate. You want to make sure the rhythm's best. Best rhythm, of course, is sinus rhythm. After that would be A pacing. After that would be AV pacing. And after that would be V pacing. So you make sure you have a good rate and a good rhythm. Then you go to contractility. It's important not to just leap into contractility. First, make sure all the other stuff is okay. The airway's okay. The lungs are working. The metabolic situation is good. The rate is good. The rhythm is good. The more you take care of that stuff, the better the contractility part will be. So, but now we're focusing on contractility. Best way to assess contractility is take a look at the heart. You can see the heart, see how it's beating. You know from history, you know what was the EF before. You know from talking to the surgeons, you know whether it was a good operation, whether they had good targets and they could revascularize them. You know, was it a really long bypass run? The heart might be in bad shape. Short bypass run, the heart might be in good shape. So you make some assessment of contractility. From that assessment and contractility, you adjust your inotrope. So the young guy with a good heart doesn't need much, not in any inotropes. Older person, sicker person, worse heart, longer case, harder vessels, okay, that you're going to need some inotropes. But the idea is make a decision ahead of time based on what you see. Okay, good heart, don't need inotropes. Medium heart needs some inotropes. Really bad heart might need some inotropes, might need a balloon pump or something. Once you've made that decision, then you say, okay, I've taken care of A, I've taken care of B, I've taken care of C. Now you can start coming off bypass. You're in touch with perfusion because perfusion has two things. They have a certain volume over there in the pump, and it's going at a certain rate. So they might have a liter of fluid over there. Remember, they have most of the volume, and maybe they're going at 5 liters a minute. That would be a standard cardiac out. So now their rate's going to come down. They were going at 5 liters a minute, 4, 3, 2. As the pump goes down, they're going to be leaving more in the heart. So as they leave more in the heart, we have to see how the heart's doing. And that's why you're watching your vital signs and you're watching the heart to see. Is the heart managing, contracting well, generating a good pressure, good? Or is the heart swelling and not doing so well? So you assess, you're in touch with them, you're in touch with the surgeons, and of course you're in touch with the patient. Come down, down, down. Once perfusion has gone to 0, now the pump is off. Now the pump is done doing all the work. You're doing all the work now. And at that point you say, if everything is good and you're off bypass and you've gotten as much volume as you can safely get from the pump, at that point you say to the surgeon, okay, we're off bypass, everything looks good, is it okay for me to give protamine? Super important to make sure you're off pump and doing well before you give the protamine. Give the protamine while you're on pump, it's all going to clot and it's a disaster. So there is a very slow and deliberate look at coming off bypass. Now let's do it more along the lines of how it might go in real life. All right, we're ready to come off bypass. We talk with the surgeon is done with the operation. Okay, let's go through our ABCs. A, I turn on the ventilator, I make sure the lungs go up and go down. B, bureaucracy, I talk with our perfusionist. Are we warm? Is the K all right? Is the hematocrit all right? Is the pH all right? Have we been off for 20 minutes so the heart's had a chance to rest? Okay, so all those things are okay. Now, in terms of the heart, I'm going to think of C, circulation. Let's take a look at our rate. Let's take a look at our rhythm, optimize our rate and our rhythm. Let's assess contractility. Okay, based on the contractility, I'm going to adjust my inotropes. Now we're starting to come off. They're at a certain flow, the flow's coming down, the flow's coming down. They're doing less work, we're doing more work. Less volume there, more volume here. We're seeing how it's going. Adjusting inotropes as necessary. Now the pump has stopped. It's at 0. They give us as much volume as they can. Everything looks good. Now I can give the protomine. So that's a step-by-step way of coming off bypass. This next emergency is something that is forever hovering over the heads of all anesthesia providers, and that is can't intubate, can't ventilate. As with other emergencies, I'm going to go through slow and deliberate, and then we're going to go through it fast, and then we're going to do a real close-up on actually cutting your way in. Okay? So first, a slow and deliberate approach to can't intubate, can't ventilate. All right, we're going to go back in our time machine first and say the best way to avoid can't intubate, can't ventilate is to foresee a difficult airway, to remember that the glide scope doesn't always get you in, and to remember that the safest thing to do, if you're really in doubt, or if the patient presents real risk of desaturation, such as a high BMI, and do an awake intubation. I'm a big fan of awake intubations. I think it keeps us out of trouble. So the best way to do a can't intubate, can't ventilate is not to get in that position in the first place. So that's the main thing. Now, let's go through. Say you get called into a room and you hear can't intubate, can't ventilate. Let's go through some maneuvers prior to having to go right to the surgical airway. So they say can't intubate, can't ventilate. Well, first, do the standard things you do to try to improve things. Put them head up. Sometimes you take a little weight off the diaphragm and you can get a little bit air in here. You can, of course, use a nasal or oral airway. Okay, still having trouble? Hey, often when you can't intubate, can't ventilate, the LMA can save the day. The very person who's hard to intubate can usually take an LMA. So let's get an LMA in and see if we can move some air there. That'll buy us some time. So definitely try that. Now, if that's not working and really nothing's working, you've already called for help and you really need to cut them, then the thing to remember is this. If you make the decision to cut, go for it. Go for it and cut them. Cut them and get that air. Don't dawdle, don't wait. The literature is replete with people who waited until the patient was blue, asystolic, and dead, and then they decided to go. No. If you must go, then go, and go early. Don't wait until it's too late. Now we're going to go over the actual cutting your way in. You've made the decision to cut. In days of yore, we would talk about things like putting in a needle and putting in a wire and taking all this time and maybe doing jet ventilation. We're really getting away from that. When you've made the decision to cut your way into the airway, then cut your way into the airway. Make a real honest-to-God hole and put in a real honest-to-God tube. Here's a 6.5 tube, okay? The idea is you got to cut your way in, and let's do it for real. So here we're feeling the cricothyroid membrane, okay? I can feel this thing giving in here. There is some talk now about doing ultrasound of this so you can see and make sure you're in the right place. In an emergency, you might not have that luxury. So we feel the cricothyroid membrane. And then the idea here is don't cut my finger. Okay, so the idea here is to cut across this way and cut in this way and get in there. You don't have time, okay? This is going to be messy. This is going to be bloody, but the option here is death or brain injury. So make a cut. That didn't take too long. Make a good hole there and put in a real live tube. Now I can ventilate with this thing. Okay. This, by the way, is a pig trachea. You can order these. They only cost $6. So if you want to get them for your department and practice this and have your residents practice, they are, in my opinion, better than the models we have, because this has that slippery feel of real live human flesh. Okay, boom, there we go. Now I can ventilate this person. So let's summarize. It's good when you're an anesthesiologist to have rapid turnover. It's good to give a good report. It's good to finalize the electronic medical record. But the main thing we're judged on is, did we save the life or not? So one thing we want to make sure that all of our residents know how to do is to handle the worst emergencies. And the best way to do that is teach them in the simulation center. Don't teach them once, teach them a lot of times. Have them drill it over and over and over again. So when the big day comes, they're ready for it. This project looked at 5 emergencies: a stat C-section, someone coming in full arrest, someone about to have a cerebral herniation, bringing someone off bypass, and can't intubate, can't ventilate. Our goal here is to give the residents a menu of things to do so they can study it ahead of time, to give them this, a video menu, so they can see what to do, see how it's done right, and then they will be coming to the sim center and we'll be drilling these things over and over again to make sure that by the time our residents head out on their own, they're able to handle these 5 serious emergencies.